webinar from the Arizona Rural Development Council, hosted by Local First Arizona Foundation. So for anyone who isn't familiar with the Arizona Rural Development Council under Local First Arizona Foundation, we put on a monthly webinar that addresses various issues that are common and surround the development process. These webinars focus on the development process specifically to rural areas. And, what's the point of talking about issues if we don't discuss solutions? So this ongoing monthly series is titled Solutions for Rural Development. So it's important to talk about the struggles that we encounter, but most importantly, these webinars are a platform to build support towards implementation and discussion on solutions to address the difficulties that we face specific to rural areas. So this month, we're discussing rural health care and what innovative approaches are being taken around the state. As an individual, myself at least, who focuses heavily on community development, I think it's extraordinarily important to have healthy communities because you can't have economic success without healthy people. So before we get started, I want to go over a few housekeeping rules. Throughout the webinar, if you have any audio issues, just make sure that your volume is to the appropriate level. And also, if you're having visual issues, make sure all programs or other windows are closed because that sometimes creates glitches within the webinar platform. If you're having severe issues, you can try logging out of the webinar and then try logging back in. Additionally, you'll see there's a chat box where we typed good morning. You can type into there and let us know if you're having any issues or something like that. And that will alert us to figure out what's going on. Now we're going to be holding question and answer until the end. If for some reason you have to leave, but you have a question that you're interested in having addressed, you can type it into the Q&A and I will read it out loud at the end and we will get that answered. And because the webinar is being recorded, when it's all done in about a week to 2 weeks, I will be sending out this recording and you'll be able to hear your question being asked and answered. So once again, if you can keep your questions till the end, unless you have to leave, and in which case just type it out and we'll make sure that question is answered. And lastly, there is contact information for all of the speakers. And if a topic that you have interest in isn't discussed, I'm sure our speakers can get you in contact with information or an individual that can better help you. So I am your facilitator, Maya Ozzie, and I am the Rural Program Coordinator for Local First Arizona Foundation. My past work has focused on natural resource management in rural areas. Additionally, I work with community development and sustainable tourism development. Our speakers, our first speaker, Jonathan Cartsonis, has been active in the health field for many years in pursuits to address health disparities and to provide medical care to underserved populations. He has worked in family medicine as a hospital physician, a medical director of a homeless clinic, and a correctional health physician. Currently, he is the director of the Rural Health Professions Program at the University of Arizona College of Medicine in Phoenix. Stephen Elston, our next presenter, is currently a health educator for Yavapai County Community Health Services. He has worked with teen pregnancy prevention, health impact assessments, safe dating, healthy relationships, tobacco education and cessation, and prescription drug overdose, to name a few. And finally, our last presenter, Ms. Alicia Thompson, is currently a doctoral candidate at the University of Arizona and is the Southern Arizona Oral Health Coalition Coordinator. Prior to returning to higher education, Alicia was the health officer / executive director of the Cascade City County Health Department in Great Falls, Montana. She has more than 17 years of experience in various public health settings and provides needs assessment, policy development, and quality assurance at local and state levels. So we're going to get started with Mr. Kurtzonis. Thank you.
Good morning, everybody. Again, my name is Jonathan Kurtzonis, and I work at University of Arizona College of Medicine, Phoenix. If some of you are not aware, but I bet many of you are. The U of A College of Medicine has split into two colleges of medicine. There traditionally was the U of A College of Medicine in Tucson, and now we have the College of Medicine in Phoenix, separate admissions process, separate curriculum, and I am fortunate enough to be the director of the Rural Health Professions program at the College of Medicine Phoenix in downtown Phoenix. Kind of an unlikely name for a position located in downtown Phoenix. It takes me across, the responsibilities take me across the state, however, and I find myself in rural Arizona quite often. So what I wanted to do was describe to you all activities that are going on through the Rural Health Professions program, and to, describe to all of you the basis, the funding mechanism, and some of the goals involved, and specifically the program that we've created. We, at the University of Arizona, in the colleges of medicine, we really we recognize the acute need for rural physicians, for rural healthcare providers, and many of you may be aware, but physicians in rural parts of Arizona are nearing retirement age. Average age is of a physician in rural Arizona is above 50. And, we expect acute shortages within the next 10 years for that reason. And perhaps as many as 400 physicians will be needed in rural parts of Arizona, just to get us up to the levels nationally recognized as necessary for the population in rural Arizona. Therefore, we are taking seriously an effort to encourage rural practice, and we have primarily a good deal of funding through the medical school itself, and also through Arizona AHEC, Area Health Education Center. And there's a little bit of interesting background related to all of this. And you'll see on the slide, in about 1996, the Arizona State Legislature passed a statute that required universities provide rural training to medical students, and not just actually medical students, but the requirement was that 15 U of A medical students would spend at least 1 month across 3 years of medical school in a rural setting. Requirement direction, that requirement did not at all prior to that. In addition, 4 U of A pharmacy students, 4 U of A nurse practitioner students, and at ASU, 4 nurse practitioner students were required, as well as 2 NAU nurse practitioner students were required to be in the rural setting for a period of time. A lot of this effort was originated with kind of a visionary in rural health. His name, he was a family physician. His name was Andy Nichols, and he was in the state legislature and really had a vision for meeting the needs of rural communities in Arizona. And he figured out funding mechanisms to make these things happen and really created a great legacy. So I think it's worth mentioning Dr. Andy Nichols and his efforts. So, what does rural mean? It's according to statute, that's what we follow. The definition, according to ARS 15-1754, pretty straightforward. A county with a population of less than 400,000 people, according to the most recent United States Census, or, and I apologize for the formatting the slide, a census county division with less than 50,000 persons in a county with a population of 400,000. For all intents and purposes, that leaves us with everywhere except Phoenix and Tucson counts as rural according to the definition. I already went over some of the points with this slide. We have 2 medical schools. By the way, I'm representing College of Medicine Phoenix again. I do have a counterpart in Tucson who does very similar work with the program that's much more established in Tucson, Dr. Carlos Gonzalez, also a family physician and also a rural, he has worked many years in Patagonia, rural community there. So what I want to go over, and it's a little bit of nitty gritty and I don't want to bore you with too many details, and I'm assuming that you do want to hear about some of them. But we have requirements for our students who join the rural track, and we call the rural track a rural certificate of distinction. The students who complete all of the requirements end up with that honor certificate of distinction on their transcript by the time they graduate. And they also get something extra in something called a dean's letter. It's a very important part of medical school process. A dean's letter is sort of a summary by the dean of students, summary of the student's progress through medical school. And it's several pages outlining the achievements, perhaps the challenges, the extra efforts that the student has undertaken in medical school. And participating in the rural certificate distinction gives an extra something that can be mentioned in this dean's letter, and it can highlight an extra effort that the student has put in towards underserved communities, including rural health. And so it's really an opportunity for the student to stand out. Now, I didn't say why the dean's letter is important, but in the application to residency programs, they rely heavily on the dean's letter to get an understanding of the capabilities and passions of the medical student as viewed through the medical school. And it can have a big difference, make a big impact on where a graduating student is admitted to do their residency training. Anyway, so some of the requirements of our program really emphasize requirements that we know from research in the academic realm that make a difference in decision making for students later on in their careers, and specifically the decision whether or not to practice in a rural area. So we may have students, and we do, who hail from rural parts of Arizona and other states, for that matter. But in 4 years of medical school, a lot of things can change. They may find a partner who's from an urban background. That student may develop ties in the urban setting that make staying in that urban setting more attractive than going back home. There can be a number of factors that lead to students not returning to a rural area if they are rural inclined at the time of admission. Well, uh, part of our effort is to ensure that we have the longest exposure possible uh, to rural Arizona, specifically if possible, the communities that student was raised in, that they return to that community and continue to get their medical education in that community for the longest period of time that I am able to negotiate and put together for that student. Um, so that's a goal, is to place a student back in the rural community where they came from. There are students who have urban backgrounds. Currently, we have a student from New York City who was interested in going through the rural program. Um, Completely opened her eyes to the possibilities that she couldn't even really conceive of prior to a longitudinal experience in a rural Southwest community. Um, so anyway, that's one of the objectives. But I'll go through some of the nitty gritty. In years 1 and 2, we require an application. All of our students at the College of Medicine are required to do a 4-year scholarly project. That's an original research project. That is, it's really quite a rigorous process. And while some of their classmates may be studying aspects of molecular biology and genetics, in the laboratory, our rural students are required to do a rural relevant scholarly project, and have over the years have done some interesting studies. They have to attend. They are required to attend 16 noon seminars throughout the first 2 years on a rural topic that we arrange for them. We also send them out for an early clinical experience, typically in medical school. The main clinical actual care of patient experience occurs in the 3rd year. We're able to get our students out there in year 1, out to the rural community where they will return in 3rd year for further training. And it's, I think, a really attractive element to the students who really came to medical school in most cases to practice medicine. And in our case, we get them to the rural community where they will return in 3rd year. So in getting to year 3, we send our students for nearly 5 months of rural clerkship experiences. Clerkship is the name for the rural clinical training, or the clinical training that takes place in the 3rd year with actual patients and learning the practice of medicine as opposed to basic medical sciences. They get 6 weeks of internal medicine training, 6 weeks of family medicine, 3 weeks of outpatient pediatrics, in some cases 4 weeks of surgery, and in some cases 6 weeks of psychiatry. We are able to cover housing and transportation costs and provide a small stipend. It can be prohibitively expensive for a student to maintain home in Phoenix near the medical school, and then we ask them to go to a rural setting, and they have essentially doubled their living expenses maintaining 2 households. So fortunately, we are able to help them with housing. Some of the sites will provide free housing, and we can cover transportation costs. Year 3, when they're done with their experience, we ask our students to write, answer some questions about their experience, to reflect on the experience, to process the experiences, and get it down on paper and submit to us for review. I think it's an essential part of our program, kind of in effect forcing the students to slow down for a moment. Medical school is a very busy time, and reflect on what they've seen and what they've done in the rural setting. Finally, in year 4, students go through have the opportunity to do rural clinical electives. And in some cases, we are initiating now emergency medicine clerkship. It's a required clinical experience, but it'll be in a rural setting. I think I told you that clerkships happen in the third year. Our school is a little bit complicated. We do have an emergency medicine clerkship in the fourth year. I already noted the dean's letter and transcript noting completion of the rural certificate of distinction. So what I really envision, I think I want to get back to a little bit what I have experienced and also have learned in my role as the Rural Health Professions Director, and that is that that communities really depend on having health care where they live, where they work, where they raise their families. And if healthcare is not available and there is no doctor, there's no physician assistant, there is no nurse practitioner, there are real and present hardships. I can recall patients of my own who, when I was practicing on the west side of Phoenix in Avondale, traveling 60, 90 miles to come to my clinic to get prenatal care and having to set up with friends and neighbors to live as they awaited the delivery of their baby. Real hardships. And it's also, you can see how development might be stymied. Perhaps I'm telling many of you things you already know, but getting fresh blood, new people to move into an area, having economic development is difficult if you don't have adequate health care in the community. It can be difficult to recruit others into the community, including healthcare workers for that matter. So we really recognize how important it is that we be successful with our students. So we have some plans in the making, and I think we could even be more effective if and when, and we are working on these issues, we start to effectively recruit rural Arizona students who are good candidates for the College of Medicine. Perhaps, we've already started engaging local leaders to recommend students who may be ready to join some of our pipeline programs. We have something called Summer Scrubs for high school students to be in residence in downtown Phoenix and go through a mini medical school experience. All of our effort to make contact with these students in high school years and follow up with the promising students and develop a relationship with them, hopefully recruiting them ultimately in the rural certificate of distinction that I described. We want students who have an interest in family medicine or general surgery at the outset, general rural surgery at the outset. Surgery is another, primary care and surgery, specifically family medicine and surgery, are two essential elements for a community to get comprehensive medical care. If you have a family physician and a general surgeon, you likely can have most medical issues covered in a community, at minimum with those two specialties. And there are shortages of both. So when a student comes to us and states that, or a potential student states that they're interested in family medicine or surgery, we know that they are more likely to actually end up practicing in a rural area. There are some studies around the country that show that to be a good predictor of eventual rural practice. When we have rural students who come from a rural community, that's another factor that increases the likelihood of a return to that rural community. The longer our duration of training in the rural setting for our students, the again, the greater likelihood those students will return to the rural setting. So, I'd like to mention too that medical school is just one part of the medical education process. After medical school, there is a big component of education called residency. And that's really where students gain the practical skills that they need to eventually practice medicine. If a student takes a residency, wherever students do their residency, they are more likely than not to remain in the community where they've done that residency. One of the, in my view, one of the benefits of the Affordable Care Act is that it funded rural residency programs, kind of a novel concept, but we now have a developing program in Flagstaff, for example, that began training family physicians in Flagstaff, finally getting our students out of Phoenix and Tucson metro areas and into Flagstaff for their residency training. And then there is another program in family medicine located in Yuma that also trains family physicians. In my view, we need a lot more than that. We need more rural family medicine programs scattered across the state, offering opportunities for our rural students to continue to have continuity from medical school through the residency process. That's really, in my view, the way to up the numbers of rural recruits. So a number of us are working on these efforts, by the way, at the University of Arizona in Tucson and in Phoenix. Currently, I don't think this is our exhaustive list, but these are some of our more established sites. We have rural training sites in Prescott, Payson, on the Navajo Nation, Fort Defiance, Kingman, Morenci, Page, Payson, Prescott, Yuma, Show Low, Snowflake, and also in Silver City, New Mexico. This is just mentioning Silver City, New Mexico, not far from the Arizona border. These issues are really regional. They don't suddenly disappear. The lack of healthcare providers doesn't suddenly disappear when you cross an imaginary border. Exists in Southwest New Mexico. We benefit from the rural programs at the University of New Mexico. And just as I hope that the people in New Mexico will benefit from our program. Just a map showing those sites with stars. This slide goes through the requirements of, or some of the background to the Tucson program, which started in 1996. And they have, being a more established program, many more sites. By the way, our program has been in existence for about 3 years. So what is that? 2014 is our starting date, and in Tucson, 1996. So outcomes, Tucson has quite a bit of data to show students who participated in the Tucson rural program, looking at outcomes. And you'll see on the left-hand column the year, and then you'll see the total graduates from the University of Arizona in Tucson. And you'll see the percentage. So it says all grads in one column. It says all grads entering primary care residency. That's a really important indicator. In my view, we don't graduate nearly enough primary care, but it says 53% total. But when you look at the rural graduates, the rural program graduates, if you move over to the right, word column, the right word column, 78% of the rural program graduates go into primary care. 48% of those are doing residency in Arizona. And then in terms of rural practice, there are a total of 47 physicians in rural practice who are graduates of the University of Arizona program in Tucson since 2000. Here's a quick busy list of all of the sites that are accessed by University of Arizona College of Medicine Tucson. We cooperate a bit in the two colleges and share training opportunities as needed. And here's a map depicting the sites that are accessed. There's some minor differences between the two programs. I would say that one of the biggest minor differences, if that makes sense, is the Phoenix program's emphasis on longitudinal experiences in one community and not rotating around to different rural communities. I'll probably skip through this slide. I want to also acknowledge Dr. Gonzalez's slides, and I appreciate him contributing them to this presentation. And I know he is passionately devoted to increasing representation, increasing the recruitment of rural physicians in rural parts of Arizona. He and I are working very, very hard to do a even better job of making that happen. Thank you for your time. I think I'm done presenting to you.
All right, thanks, Jonathan. And thank you, Maya, for having me be a part of this. My name is Stephen Elston. I am a health educator with been with them for a number of years, on and off, working with different grants. Right now, I'm focused on prescription drug overdose issues in our area, but for the rest of these slides that I go through, I'll mention some different incidences and issues of outside of prescription drug overdose as well when it comes to rural health. So in Yavapai County, as you can see, we're kind of the heart of Arizona there. Some of you may recognize the cities that are in Yavapai County. Some of you may not. There are some very rural areas of Yavapai County. Total population is about 222,000. Prescott is the county seats, right at about 40,000. The Quad Cities area is kind of a name for a group of different cities, which includes Prescott Chino Valley, Dewey Humboldt, and Prescott Valley, plus a couple more, equaling about 103,000. And then on the other side of Mingus Mountain, you have the Verde Valley, which includes Cottonwood, Clarkdale, Camp Verde, Cornville, Lake Montezuma, Jerome, and Sedona, right at about 33,000. And you have some pretty outliers when it comes to rural areas. Baghdad, which is quite a drive out there, Ashford, Seligman, Yarnell, and Congress. Some of the public health concerns in our area, of course, that Jonathan mentioned earlier, across the board in the state, we certainly have an older population that are more likely to live in poverty in the area, more likely to be uninsured. We're definitely less healthy than the urban counterparts. We have pretty limited access to care. There is a lack of professionals, and once again, in Jonathan's presentation, that may continue. However, gaps in services still exist. And then we do have a fair amount of tribal communities in our area. And a lot of times in those tribal communities, these public health concerns can be magnified. In Yavapai County, after taking a look at kind of the geography of Arizona, when you start heading north, there becomes an issue as far as state medium households. So for the state of Arizona, about 49,000, which is about 6,000 more than Yavapai County's median income. But the issue there lies with the higher costs of living in the area. So of course that creates some health issues as well. Furthermore, interesting fact at the bottom, 2014, the Census Bureau determined that approximately 16% of the county is below the poverty level, with 28.3% of the Hispanic or Latino population living in poverty as well. So as you can see here, we kind of have an issue, whether it be good or bad. If you notice right around here, kind of in center top right, we have the Cottonwood area. This is the Verde Valley, and separating Prescott and Prescott Valley and these cities here is Mingus Mountain. And a lot of people in the Cottonwood area will commute across Mingus Mountain, which is the quickest way. But you know, I'm just putting this out there because sometimes the geography as far as distance goes, sometimes that's good, sometimes that's bad. After living on both sides of the mountain, there's certainly, you know, different politics, different ideology, cultures, different, and once again, whether that's good or bad, that's kind of for the residents to decide. Sometimes, of course, with rural health issues, that can certainly be a bad thing. Can access be the answer? That always comes up in public health. It's just access to what? So access to jobs, entertainment, access to healthcare. Is that the answer to solve some of these issues especially for Yavapai County in rural Arizona? A lot of times it can be. So I'll take a look at this map here again. When it comes to access, the first thing I always think of is actually where we work. We do have a community health center in Prescott, and as well as a satellite office in Cottonwood. So just as an example of why access can be a concern, we have a wonderful clinic in our facility, but not too long ago, we had to move from kind of the center of Prescott area over to kind of the outskirts of town. A lot of that has to do with bids and funding. But you know, when I think of access to healthcare, you know, this is a really important area for the community to come to. And right now, we don't have, in you know, a lot of people's opinions, a great resource to get there if you don't have a vehicle or if you don't have money, and if you're at or below the poverty line. Here's just kind of a picture of the office there. So, of course, as an example, and this happened not too long ago, but you know, it's come up so much that you know, public transit for the Prescott area. How do we get it? When do we get it? And a number of years ago, we exceeded a population amount for funding to be able to actually get one started. And for some reason, it's been kind of shot down for year after year. And so we came in, we got a little bit of funding, and we created what's called a health impact assessment, which we basically pass out different flyers and information throughout the community, and asking, you know, do you have access to a vehicle? What are some of your health complications? And the numbers were pretty amazing. And you know, one thing when we looked at throughout the health impact assessment was you know, how does it positively impact our community? And so some of the health issues we took a look at in categories would be physical health, mental health, and social health. Of course, cardiovascular disease, diabetes, regular physical activities, injuries and obesity, depression, isolation, stress, and access to services. Here's kind of the breakdown when it comes to comparing Yavapai County to Arizona. As you can see through the graph, cancer, chronic lower respiratory disease, heart disease is right up there. Suicide was a big issue after taking a look at it. I'll show you on the next slide. Suicide rates and mental health is a big concern. This data comes from 2014, which is the suicide deaths per 100,000 in population. 16.5 was the state number. As far as 2015 goes, this slide, actually that information just came out, but it actually came out to, I believe, 31.5. And that's huge. A lot of ways to deal with that could be, access to entertainment to decrease depression. So here's kind of the final results of the, public transit. Is it good? Is it bad? Access to healthcare could bring access to education, access to employment, recreation, and so forth. And finally, the health impacts could lower obesity and other chronic diseases, mental health, air quality, and there's a slight decrease when it comes to health and injuries of cyclists inherently with traveling to bus stops, things like that. So what were the barriers? Of course, this is just an example of some of the things that we've seen, but of course, stigma against people maybe who do need to use transportation and views on that. Sometimes political differences could play a part in being a barrier to passing something like this. Empathy for people who don't have access to vehicles or who can't get around. And it could be disconnection, collaboration. Some cities work better than others when it comes to getting together to create something like a network of transportation. So that's just an example I wanted to give. I thought that was kind of nice. So basically what we're focusing on now is prescription drugs and heroin, and that's kind of the focus of what I do. Interesting things, there's been a 4-fold increase in the quantity of prescription pain relievers sold in the US in the last decade. The United States makes up about, right about 5% of the world's population, but consumes 80% of prescription opioids. 91 people die in the US from opioid overdose, and about 1 death per day in Arizona due to prescription opioid overdoses. Prescription pain reliever deaths are greater than heroin and cocaine combined. This was kind of the biggest turning point that pushed our country, as well as Arizona, into putting more of a focus on opioid overdose and deaths. So right around 2008 is when the drug-induced deaths surpassed motor vehicle crash deaths. And so you see that a lot. There's different graphs out there, but that really was a big turning point. Volume too is an issue. There's enough pain relievers were dispensed last year to medicate every adult in Arizona around the clock for 2 weeks straight. And there's all sorts of statistics out there of just quantity that's out there, and I'll go into that a little bit further. How did we get there? So in about the 70s, 80s, and early 90s, we started seeing some pretty prevalent issues with overdose and abuse and misuse of prescription pain killers. And back then, as far as the drugs and the research that I've done, there was a big push for marijuana and cocaine to get that off the streets, to put better messaging out. But that really changed to try to decrease the amounts of painkillers, pain pills, and pain prescriptions. 1996 was really the birth of OxyContin. It's Purdue Pharma, who's now been sued for millions of dollars, unfortunately for them. They put out all sorts of advertising even in different journals, they would put, their images of how safe OxyContin is. It's not addictive, and messaging like that. And so in about 2001, we created, or different organizations created, the fifth vital sign of being pain. And so that really kind of pushed physicians and prescribers to address pain seriously and take that seriously as far as distributing pain medication like OxyContin. And unfortunately, about 2010, there was lots of different regulations due to the negative health impact of prescription opioids, enough for us to create different deterrents, change around the composition of the drugs to make it easier to, or I'm sorry, more difficult to crush, more difficult to shoot intravenously. And so people started turning from opioids to heroin. In 2011, it says, if I had an inkling of what I know now, a kind of interesting quote here. What I was trying to do was create a narrative so that the primary care audience would feel more comfortable about opioids in a way they hadn't before. In essence, this was education to destigmatize, and because the primary goal was to destigmatize, we often left evidence behind. Clearly, if I had an inkling of what I know now then, I wouldn't have spoken in the way that I spoke. It was clearly the wrong thing to do. So there's a lot of regrets around decision to distribute pain pills, things like that. And in March 2016, we know of no other medication that kills patients so frequently, and that's right from the CDC. So that kind of brings us to today. And in Arizona, we adopted a program called Prescription Drug Misuse and Abuse, and that's directly funded from the CDC, and ADHS is kind of spearheading that. A number of different counties got it, and we're happy to get it as well. This strategy for the misuse and abuse initiative really has two parts to it, at least just for us. One's to promote the responsible prescribing and dispensing policies and practices. And a lot of that has to do with the Controlled Substance Prescription Monitoring Program, or you might see it as PDMP, which is a Prescription Drug Monitoring Program. And another big focus is to just decrease, of course, the quantity that's out there. So creating drop boxes for folks who have excess meds or meds they're trying to get rid of, to take them down to these safe boxes that are usually controlled by law enforcement. In our area, most of them are going to be with like in sheriff's offices, things like that. But we're really trying to work with pharmacies to adopt a drop box program. So access to drop boxes is certainly an issue as of now, and even the stigma as well. A lot of times people have an issue bringing their prescription drugs to a drop box because they don't want to be seen as someone who has collected prescription pills over a period of time. Kind of the second strategy is to enhance the assessment and referral to treatments. A lot of that has to do with what's called SBIRT. Some of you may or may not know what that is, but it's a screening, brief intervention, and referral to treatment. And that really, for us, the focus is a lot on prescribers knowing warning signs of addiction, how to treat that, and how to actually get them to proper treatment. And actually, a lot of the treatment has to do with medication-assisted treatment as well, which is pretty slim in Yavapai County. So when you take it a little bit closer to home, Prescott, Arizona is a rural area, but it also has its own unique sort of tourism. It does have a population of 40,000, but roughly 6,000 people come there for their rehabilitation or treatment centers. There's just over 150 programs, and I think that number might have changed, but I don't have that current number. Most of the programs follow a the 12-step method, which for a lot of people works, but we know that the success rate is somewhat low. And of course, that's an abstinence-based program. 57% of people seeking treatment for HIV and or hepatitis C have used injection drugs in the past month, and 88% shared needles during this time. And so when we talk about health issues, so we know that we've worked on prescription pills for a while and decreasing the amount, but they can go to different opioids and illicit opioids being heroin as well. But drug use isn't the issue here. It sometimes can be a cause for different health issues, and that being bloodborne pathogens. So HIV and hepatitis C, people choose to inject drugs intravenously. And I'm really happy to get these numbers from Northland Cares, and it's pretty high. And if I had to guess, if there's going to be an increase of heroin abuse, there's definitely going to be an increase of bloodborne pathogens as well. And needle exchange programs are illegal in Arizona. So I'll go on it more in the next slide, but needle exchange programs are a method to try to decrease that. However, they happen to be illegal in Arizona, so sometimes the law is a barrier as well. Sometimes money's an interesting thing to look at when it comes to public health issues. Hospital charges for non-fatal poisoning related inpatient hospitalizations totaled more than 213 million in 2013. The average hospitalization costs over 32,000. And arrest costs, 3 out of every 1,000 babies born between 2008 and 2013 had neonatal abstinence syndrome, which is caused through, of course, opioid abuse during birth. 2013, 645 newborns were identified with the presence of narcotics, and there's an average neonatal abstinence syndrome birth cost just about 31,000 versus 2,500 for non-NES births. So, of course, aside from the strategies that we work on with the Misuse and Abuse Initiative, other approaches do exist. One moment. Other approaches do exist to kind of fill in the blank to create a more comprehensive approach, that being treatments and increasing treatments and decreasing the stigma towards medication-assisted treatments, addressing how the law interacts with public health. So there's kind of a bigger push nationwide to instead of incarceration as a penalty for abusing narcotics or illicit drugs, to provide treatments instead of for that, and really just kind of changing words around and looking at addiction as a disease and treating it as such. Another kind of innovative approach is providing naloxone to those who need it. It's been around for a while in the state of Arizona. Naloxone, I'll get to this side. Arizona House Bill 2489 was passed just recently, April 10th, 2015, that allows lay people to administer naloxone. And that's a huge, huge deal for Arizona. And if you don't know naloxone too, it's an opioid antagonist that if somebody were to be overdosing on an opioid and the opioids are attached to the opioid receptors in the brain, this naloxone or Narcan, when administered, goes right to those opioid receptors and kind of rips and replaces the opioid out from the receptor and adheres itself to the receptor. There are barriers to naloxone. Naloxone in these previous slides do come in different versions. This is a nasal naloxone intranasal device. There are intramuscular, so of course a syringe is needed for that, and then a more kind of fancy version where it's an auto injector. So when it comes to The barriers with that, needles, like I mentioned before, can be looked at as, a drug paraphernalia. So sometimes law can be a barrier. And stigma, a lot of times people don't understand what naloxone is, so educating on that is important. And really focusing on harm reduction coalitions in our area. We do have one that focuses a lot on naloxone right now, called Sonoran Prevention Works, and they've been working really hard to utilize this new House bill change and get naloxone in the hands of people who need it. Other comprehensive approaches that we're looking at, as well as other states, would be just the harm reduction model, which is any positive change. So if you look at harm reduction, kind of an example would be seat belts. We know people are going to drive even though accidents happens and vehicular, death and injury happens. How about seatbelts? We can't stop you from driving, but we know we can decrease the damage to your body. Better drug surveillance is also being looked at. So testing bodies as they die. We see differences in drugs too. So if we were to test bodies for what drugs are in their system, we may see trends such as fentanyl. And fentanyl is a pretty powerful opioid. It's about 30 to 40 times more powerful than heroin. And if we just understood, what's being mixed, what's causing people to overdose, we'd have a better idea of how to suppress injury. And real-time testing for laced and poisoned drugs is important as well. And there's some devices out there that are pretty cheap that we're able to get into the hands of people who may choose to use drugs, so they can actually test their products. Because in a way, if fentanyl were to be mixed in with these drugs, it's poisoned. And a lot of times when you buy drugs illicitly, they're not telling you that there's fentanyl in it. They're not telling you the composition. You're just purchasing the product as heroin. And last would be safe injection facilities. Some bigger cities are taking a look at this, who have issues with heroin abuse. So like New York, Seattle, they're, once again, there's a stigma against safe injection facilities because it, from what I've heard from people, it's oh wow, we have people using on the street, but that would just allow them to use. But what these facilities really do is they offer support. They offer a chance for people to seek treatment, medication-assisted treatment. They provide clean needles, which is important to decrease HIV and hepatitis C. And of course, at the bottom, public bathrooms are not adequate, and people do use, if they're using a drug, they're going to find wherever they can if they don't have the proper place to do it. So that is about it. Quick run through, and I appreciate your time. And of course, if you have questions at the end, you can ask. Thank you.
Okay, thank you, Stephen. I need to move forward to my first slide here. So we're going to switch gears and we're going to talk about oral health and a potential solution for rural Arizona. So I want to start off with, though, talking about the causes of the epidemic of tooth decay and other oral diseases. And as you can see from this diagram, tooth decay and oral diseases are very complex. There are a multitude of reasons that people experience tooth decay and develop other oral diseases. But the three main categories are a lack of knowledge and awareness. And I always take the opportunity to address the fact that tooth decay is actually a chronic bacterial infection that is contagious and preventable. And most people are not aware of that. They believe that the cause of tooth decay is eating too much sugar, but it truly is being infected with a bacteria. that leads to tooth decay. The other is lack of access, which is what we're really going to focus on today. Because if you don't have the ability to first be able to get the prevention tools that you need, the toothbrush, the fluoride toothpaste, dental floss, and you can't get to a dental provider to have your teeth cleaned regularly, you're going to have a real challenge of having a healthy mouth. And lastly, there's this lack of medical oral health integration. It's almost like the body doesn't start until the throat. And we really need to work towards integrating oral health with medical health because as research is progressing, we're finding that there is a huge link between poor oral health and poor physical health. And so, with oral health and tooth decay being an infection, if you have an infection in your mouth, the rest of your body is infected. Um, in Arizona, in our rural areas, the lack of access is really magnified in our rural areas of Arizona, and that's what I want to talk about. And this is just a really quick picture of the results of a lack of access. And what you're looking at are results from a 2015 survey. This represents third grade children. There were over 2,000 children that had actual dental screenings. So it's a clinical screening, not self-report. And what this graph is showing you is that an average of 28% of Arizona's third grade students had untreated tooth decay. And you can look for your county on this list, and you'll see that there's a disparity in the prevalence of untreated tooth decay. Here's Pima County is where I'm at in Tucson, but look at Navajo, look at La Paz, look at Greenleaf and Apache. I mean, to have two-thirds of your third graders sitting in class with untreated tooth decay. And again, these are clinical screenings. So it's not questionable as to whether or not this percentage is accurate. And these are averages. When you look at these third grade students by low income, or whether they're American Indian, or if they're Hispanic, the prevalence is even higher for those children. And the disparities between the counties here is obvious. So what's really going on? You know, all children should have dental coverage, whether it's through their parents' employers insurance, their marketplace insurance, or Medicaid, which in Arizona is called Access, the Arizona Health Cost Containment System. And so the children that are on Access, they're the ones that have this higher prevalence of untreated tooth decay. And this statistic here, the way to read it, we have our Medicaid program Access reports that we have one dentist that's enrolled to provide services to Access patients for every 1,279 of the population. And they say this exceeds our goal. The number of dentists that we're trying to have enrolled exceeds our goal. But then they add this caveat. It doesn't take into account geographic regions. And so that's one thing. Then there's this other thing that same survey that I just showed you the statistics from, it uh, it found when it asked the parents of these children, what insurance do you have? The parent says, oh, my child's enrolled in Access. And then they ask the parent, what does your child have dental coverage? 1 in 5 said, no, child doesn't have dental coverage. Well, every single individual that's enrolled in Access who is under the age of 21 does have dental coverage. So there's a need to increase the knowledge of whether or not children have dental coverage. And then when you look at whether or not did those children, did those individuals enrolled in Access, did they get care? Nearly 40%, 4 in 10, did not have a single visit to the dentist in 2013. And the recommendation is that every person alive should see an oral health care provider at least twice a year to maintain good oral health. So this, you've seen a lot of maps today. This is another one. What this is showing is the dental health professional shortage areas in Arizona. And all of the colored areas on the map show that just about everywhere in Arizona does not have enough dental providers to provide care. And actually, the only areas that have enough providers are the areas that are in white. And you can see that that's a very small portion of Arizona. People who live in these rural areas of Arizona who have the ability to travel long distances and to get to a dental provider, they may just see this as an inconvenience. But people who do not have the resources to travel long distances, kind of like what Stephen was talking about with the Prescott area and the transportation issues, they don't have the ability to travel. What happens is they just end up going without care for their mouth, and they end up with untreated tooth decay. Now, similar to what Dr. Kartsonis was saying, the efforts to try to attract dental providers, oral health care providers, has been really stagnant. You can see this graph shows from 2009 through 2016 the number of Access enrolled dentists and dental hygienists, and it's broken down between urban and rural. And you can see that they're really all the efforts that have gone into attracting dentists and dental hygienists to these areas have really not worked. It's just remained stagnant. And what is often said is that this green line, which is the reimbursement rate for the Access providers, that if that would just go up higher, then we would have more people who are willing to take Access and provide care to those individuals who are most at risk of poor oral health. However, other studies have shown that yes, it does increase the enrollment, but it doesn't increase the utilization. And we believe that that is because the providers aren't where the greatest population of risk is located at. And so what the Southern Arizona Oral Health Coalition is advocating for is dental therapy. And so what are dental therapists? Um, they are like a mid-level provider. They're like a nurse practitioner or a physician assistant. And in addition to regular cleanings, they can take care of tooth decay by numbing the mouth and drilling out the decay and putting in a filling. The other very important thing they can do is provide education about how do you prevent tooth decay from the very beginning. They can also pull teeth. And currently, dental therapists are not allowed to practice in Arizona. And in order for Arizona to have this type of a dental provider, legislation has to be passed. In other parts of the United States, we are seeing that states are beginning to pass legislation that would allow dental therapists to provide care to individuals. And Alaska and Minnesota are the two states in the United States that have had legislation the longest. And both Alaska and Minnesota are seeing increased access to care and decreases in the prevalence of untreated tooth decay. They're also seeing better oral health overall and all the benefits that come with it. And so what we're hoping for is that in Arizona, that there will be legislation that allows the licensure of dual degree dental therapists. Similar to what Dr. Kartsonis was talking about, we are hoping that this legislation will encourage and support the ability to recruit these individuals from within the communities that are underserved. And you can also translate this as new employment opportunities for your community members. And this has worked beautifully in Alaska's tribal communities, where they have very remote communities that just had rampant tooth decay. And they started over 10 years ago, they started their dental therapy program. And now those very remote communities have ongoing regular treatment for their oral health care right there in their communities. We also are advocating for the legislation to include the requirement that these dental therapists are required to see like 50% of their patient load has to be from an underserved or a shortage area, because we want them to actually be working in the communities that need the services. We're we don't want to see them start working in Tucson and Phoenix with the for-profit industry, so that the for-profit industry can just make more money. We want to see them out in the rural communities, in the assisted living facilities where there's hardly any oral health care available, in the communities where it's very difficult to reach the individuals. So that leads to this next point of we've heard about the transportation challenges. So if this piece of legislation also supports the ability for these dental therapists to set up a clinic in the school that's right there in the community, that really addresses the challenges, because they're in a place where the people from the community go anywhere. It's local. It's right right in their neighborhood. How's this going to happen with supervision, you might be thinking, but wait a minute, this is a dental therapist. They have limited scope of services that they can provide. Every single state that has this legislation addresses this issue, and it's just general supervision or direct supervision. General supervision actually allows the dental therapist to work under the authority and guidance of a dentist, but the dentist does not have to be on site with the dental therapist. And so in Arizona, in order for this to actually help address the epidemic of tooth decay in our rural areas, they need to be allowed to operate or to provide their services under general supervision. And we can do that using technology now. I know that there are parts of our state that have limited technology or access to technology, but that is an ongoing thing that's being improved throughout our state. And then finally, the legislation needs to ensure that the reimbursement rates stay the same. In other words, right now, there are reimbursement rates, whether it's through access or other dental coverage, those reimbursement rates need to stay the same regardless of who is doing the procedure. If it's a dentist doing the procedure, you get reimbursed at this rate. If it's a dental therapist doing the procedure, they get reimbursed at the same rate as the dentist. So some concluding thoughts here is that oral health, it's it's equivocal, no question. It's a problem in Arizona for many. It is the most chronic condition other than the common cold that people deal with. It's preventable, but people need to have the tools to to prevent it. And one of those critical things is access to oral health care and to attract and retain the dentists or other oral health care providers to rural areas. They've been pretty abysmal, and you can see from the chart I showed previously, totally static. And we know that doing the same thing is just going to produce the same results. We also know from the other states and a lot of other countries that have dental therapy that it truly does move the bar on oral health disparities. We also know poor oral health is costly. This is a young man who lost his life to untreated tooth decay in January of 2017. This is another young man, Diamante Driver. He lost his life to tooth decay in 2007. And I wish I could say that these are the only two examples of tooth decay being allowed to advance to the point where the individual develops an abscess, and then the infection from the abscess moves on to the brain and kills the individual. But they're not. It's not as common as what Stephen was showing with the drug abuse um, issue. But I mean, my research, I've also found Kyle Willis, who died in 2011, and Alexander Callender, he died in 2007, just a week after Diamante Driver did. And there's been many others for a preventable condition. So, therefore, the Southern Arizona Oral Health Coalition advocates for, supports, and encourages others throughout the state to support the passage of legislation for the licensure of dental therapists. This is truly a policy that has the potential to improve the lives of rural and underserved Arizonans, and not in just access to care, but also opportunities for employment. And anyone who knows anyone who has rampant tooth decay, their ability to find a job, their ability to pay attention in school, they're just not able to achieve their full potential. And this particular policy truly has the potential to improve the lives of individuals on multiple different levels. And then finally, other solutions haven't been found. the oral health, poor oral health has just been a real challenge for many, many years. And we can't continue to watch community members suffer due to the lack of effective action. And so that one of the main reasons that I was very delighted to be able to be here on this webinar is to encourage all the participants that are work in their rural communities to, as this legislation, hopefully, we tried to get a sunrise application through in 2016. It failed. Um, but we are going to come back in the fall of 2017 with another piece of legislation trying to get dental therapy passed through our legislation so it can be those services can be provided in Arizona. Lastly, just wanted to do a shout out for our coalition. This is our vision and our mission. And this is my contact information for the coalition.
Thank you so much, Alicia. Those were all amazing presentations, and I know we're running close to our time. So we had one question. I believe this is more directed to Stephen. Is there now a fresh timeline on revisiting the status of the transit system in Prescott?
Hi, Maya. Is there now a fresh timeline on revisiting the status of the transit system in Prescott? You know, part of our HIA project is really to just try to give them all the resources they need and kind of hope for the best. There was some positive outlook as far as the stakeholder meetings went. It looked positive. If they don't, you know, go with ADOT and produce this, you know, great system, it at least I think in a lot of ways encouraged kind of more smaller nonprofits to seek out funding and realize how important of an issue it is. But as far as a set timeline, I didn't hear anything as of yet for Prescott and the Quad Cities area, and as far as the timeline being made, that's probably 2018 was the last council meeting date that I heard for anything to actually start if it were to pass.
Awesome. And then I believe this is another question that was put up during your presentation, Stephen. Is there a movement to push more direct education on your topic in our classroom?
As far as our grant funding goes, we don't have too much to do with direct education classrooms. There's kind of an interesting history when it comes to like DARE programs, and then we hear about that in education in classrooms, and it actually not so effective. There are some great programs, but as far as our county goes, currently we don't have too much when it comes to opioid education in classrooms, but I do feel that there's a great importance for that.
Awesome. Well, if there are no more questions, I just want to reiterate my thanks to the speakers. I mean, we had such a broad discussion, but the reality is we struggle with isolation, but there are opportunities, and this is just brushing the surface on the opportunities out there. So engaging with your legislation and, you know, definitely reaching back out to our speakers if there are any further questions, or if you want to be put into contact for any further information, is extremely critical. And for anyone who is on this webinar, please share this information out, and I will be sending it out to everyone who registered. So I just hope that the dialogue can continue moving forward. Just before we go, I want to let everyone know that next month our webinar is titled How to Leverage Marketing Through Business Partnerships. It is free. It is on the last Wednesday of the month. also from 10 to 11:30. And in June, our webinar will be titled Raising Capital, Raising Our. The date is to be determined, and more information will come out on both of these webinars through our Local First Arizona Foundation Rural newsletter. So if you are not signed up for the newsletter, please send me an email and I can get you signed up on that. And then also we do a lot of promotion about different grants and opportunities and just like general information on the Arizona Rural Development Council Facebook page. So please follow that if you do not already. And then this is my contact information. If you have any questions about anything or comments, please feel free to give me a shout out. And once again, thank you all for participating, and thank you so much to our presenters. And I hope to engage with you. Oh, and one more thing, the Rural Policy Forum, which the Arizona Rural Development Council and Local First Arizona Foundation hosts, registration sales will begin hopefully in the first week of May. So please look out for that. We will have information coming to you on that as well. So thank you all so much, and we will be in touch soon.